Good evening, students. So for another 12 to 15 minutes, I'll just go through what exactly is required for you for next 3 years to survive when it comes to transfusion services. The things which you should be knowing is components, what we give over here, the triggers, what you have when we have to transfuse, good transfusion practices, supposedly which will keep the patient safe, and identifying an adverse event. Uh, what we are concerned is not the benefit which a transfusion episode gives. We are more concerned the risk which is involved. Why? Because it is a drug, and everybody who prescribes and a person who gives both are at risk. If the patient goes for a medical legal, litigation will come. First, the physician is caught hold. Why he has prescribed that component to the patient, and second, the blood banker, why he has given that component to the patient. So we should be more aware about the risk rather than the benefits, what it comes with it. So risk, it will cause an infection, hepatitis B, C, malaria, syphilis, whatever. And the non-infection risk is the transfusion reactions, which is a very common thing to have whenever you're giving a component. I think everybody knows why we give a component. Red cell is to improve the oxygenation. Platelet is given to improve the platelet function of the patient. Plasma is given to improve the coagulation profile of the patient. It's plain and simple. SDPGI is the only government hospital in the country which gives 100% leukoreduced blood component. Try to understand this thing. जो भी red cell आप देते हैं, I think a bit of Hindi will be fine with everybody. Whatever component you give in the form of a red cell, there are two types of component. One is given along with WBC. Most of the centers, including AIMS, PH Chandigarh, JIPMER, NIMHANS, they give a WBC containing component. They don't have a 100% leucofiltered component. SGPG is the only center in the country, government center. I won't say a corporate sector, but a government sector which gives a 100% leucofiltered, which will keep the patients to a level which is far safer in comparison to when you give a WBC containing components. Other components what we have is of plasma, which we call a fresh frozen plasma, platelet concentrate in the form of RDPs. RDPs are the small bags which we order for transfusion, and apheresis is platelet, what we call it as a jumbo platelet, where a single dose is taken out from a donor and given to the patient. And we have cryoprecipitate and reconstitute whole blood. We don't issue whole blood at our hospital. Whenever there's a requirement, maybe in neonatology or in trauma, we reconstitute the whole blood. That is a PRBC, a pegged red cell, is again constituted back into the plasma to give into the patient. May or may not be containing a platelet, depending on the need. If the patient also have a thrombocytopenia, we add a platelet component to it. Before we start, what exactly has to be triggers? This is the one plain simple thing we need to understand. If we see the picture, the number one is the normal physiology, where the red cell mass as the plasma component is evenly matched, and in 2, 3, 4, and 5, there's an alteration in this ratio of red cell mass versus the plasma. So as per the condition, we don't have to give a whole blood. If there is reduction in red cell mass, which happens in, I would say, chronic blood loss, we need to give only red cell mass. If there is reduction in the plasma component, which happens in dehydration, we don't give a transfusion dehydration, but in a patient of burn, where there is already a induced dehydration because of the raised body temperature and burning of capillaries, we give a plasma component. So in a burn patient, for 72 hours, we don't transfuse. There's a general concept. What happens whenever there is a burn patient, we tend to give a red cell transfusion that it will improve the wound healing. No, that is not required. It only worsens the condition. So the first transfusion has to be crystalloid colloids, followed by a plasma transfusion. Similarly, for chronic acute blood loss, in this scenario, we need to give both the red cell as well as the plasma. So at SDPGI, we give a reconstituted whole blood. When we come to triggers, we compare the developing as well as the developed countries. Major differences in India, the most common indication for transfusion is pregnancy related. APS, PPS, 37% of a transfusion are given to pregnant females, whereas in a developed country, it is only 6%. So it's a huge difference where, when it comes to the indication. So luckily at SCPGI, we are quite safe. We don't have pediatrics, we don't have OBG at this. So most of our transfusions are very clean. We don't talk about those indications here. and when we compare a whole blood and a PRBC component, the increments are same. The hemoglobin will be increased by same content, but the add-on losses are there, that we won't be giving any platelets, we won't be giving any labile factors, but the citrate, if the patient is of liver disease, the citrate will not be able to be metabolized, allergic reactions will be more, there will be more chances of febrile non-inhibitory transfusion reactions and TTI, and there is waste of component. And coming to the indication for red cell transfusion, how many surgeons are there? What is the level which you transfuse? At what level you transfuse before taking a patient for surgery? I think anesthesia guy will be able to tell us in a much better way. 7. Why you take 7 as the cutoff? Severe anemia is 7. 10 is also anemia. Anything which is less than 13 is anemia. How you define a severe anemia and a normal anemia? It is because if I transfuse above 7, the benefit is nothing. The transfusion which are given at 7 try to maintain a hemoglobin of 7, which corresponds to a hematocrit of 28% to 30%. 21. That means people are awake. So 21% means 21 to 24% hematocrit will maintain the coagulation profile of the patient also. They will maintain the platelet margination. What happens when there is low hemoglobin, low hematocrit, the platelet, even if we have a good platelet count in the patient, the platelets tend to bleed because there is no platelet margination. But at a hematocrit of 24% or 25%, there's platelet margination. That's why we take that at 7, the patient is able to carry oxygen to the tissue, as well as the coagulation profile of the patient is also maintained when the hemoglobin is 7. So if it is 6, we transfuse. More than 10, we don't. If it is between 6 to 7, depending on the patient condition, we give a transfusion. I'll let you know where we can transfuse. And if there is a CPP derangement, then we can give a transfusion when the hemoglobin is less than 10. So the hemoglobin trigger was taken up in 1942 as a indicator. When the hemoglobin is low, it was taken up in 1942. So this is a few secondary indicators which will help the patient who are critically ill when to transfuse or not, such as the extraction efficiency method of oxygen. When the normal value is 25, if it is increases to 50%, then we can give a transfusion, because at that time the patient is not able to carry the oxygen to the tissues. Or the mixed venous oxygen partial pressure is less than 4.3, or the base is in excess, that is the levels are more than 30 milliequivalent per liter, or the lactate levels are more than 2.5, or the consumption has decreased by more than 10%. So these are the indications which will help you deciding when you are giving a transfusion between 7 to 9. If these are deranged, we can give a transfusion to the patient, or if they're normal, then there's no requirement for a transfusion. I think everybody got it. So this happens when you use a MacBook to make a presentation, and when it comes to Windows, it has flipped down. It's a combination of multiple RCTs. There are two therapies which we have been advocating in patients. One is liberal therapy and one is restricted therapy. Your entire transfusion practices are based on it. Liberal means we tend to maintain a hemoglobin above 9. Restrictive means we tend to maintain hemoglobin above 7. And in multiple RCTs, it has shown that whether you keep a hemoglobin of 7 or whether you keep a hemoglobin of 9, there is no difference. In fact, keeping a hemoglobin of 7 has been beneficial in all category of patients, whether it's ICU, sepsis, cardiac patient, or GI bleeding patients. Only in few RCTs, particularly related to cardiac surgeries, where they found that if we give a liberal transfusion, the patient condition has improved. So just based on few RCTs, we cannot say that 9 is better, but 7 has been better when it comes to hospital mortality or stay in hospital. It has no difference between the two strategies. Neonatal transfusion, the transfusion triggers are same, but on the higher side. I would like to emphasize, if the baby is less than 6 months, the sample has to come along with the mother sample. Post that, no mother sample is required. Hemoglobin of 8, where it was 7, we take it as 8. And in moderate cases, hemoglobin less than 10, Severe CPB disease, hemoglobin more than 13, and for major surgeries, a hemoglobin less than 10 is taken into surgeries for pediatric patients. Doses 5 to 15 ml per kg. So that was about red cell. Adult, we take a 7. For a pediatric patient, we take a Tigger of 8. For platelet transfusion, all prophylactic transfusion are done at 10 or 20. If the patient is stable, transfuse at 10. If the patient is not stable, that is has fever or bleeding, we tend to transfuse at 20. That is plain and simple. Don't have to remember anything. And if the patient is bleeding, the count is less than 50,000, we transfuse. Done. Three things for platelet transfusion. Stable patient, 10,000 is a trigger. Patient is not stable, having fever or sepsis, 20,000 is a trigger. And if the patient is bleeding, 50,000 is a trigger. We transfuse. Don't have to remember anything. 1 units, add 10,000 to everything. 20,000, 30,000, 60,000. Done. Plain simple. Don't have to see number of triggers. It's very simple in it. For surgeries, a surgeon says or anesthetist says that lac is mandatory for doing any kind of intervention. Agreed. But these are the levels where we can do simple interventions in the patients. 50,000 for puncture, gastroscopy, 50 to 80 for epidural anesthesia or for brain surgeries or any kind of surgeries, a lac is required to touch the patient. So I already told two types of components for platelets, apheresis and RDP. 6 RDP is equivalent to 1 apheresis. So when we decide a dose for an adult, either we go for a 1 SDP or 6 RDPs. But at SDPGI, we are short of blood. We are not able to give 6 RDP to the patient, but tend to give it by 3 or 4. Minimum what is required to prevent intracranial hemorrhage is 1 single RDP, which will give an increment of 7,000, which will keep the patient from going into intracranial hemorrhage. So if we get 1 also, try to transfuse, maintain the patient till we get more for it. For FFP transfusion, PT, APTT more than 1.5 times, done. If the patient is bleeding in spite of having normal PT, APTT, look for other causes. If the patient is of chronic liver disease or acute on chronic liver disease, patient is bleeding, deranged coagulation, transfuse even if the PT, APTT has turned to normal till the bleeding stops. For fibrinogen content, if it is less than 1, give cryoprecipitate, which is 15 ml bag, which will increase the fibrinogen levels. Platelet, if it is bleeding less than 50,000, is the trigger, irrespective of the condition of the patient. The dose for FFP is 10 to 15 ml per kg. Cryoprecipitate is 1 unit per 10 kg. RDP, it is 1 unit per 10 kg. What happens? It increases the count. Platelet 55,000 to it should be 10,000. Cryoprecipitate, it increases the fibrinogen level by 10 milligram per deciliter. And the FFP dose, what we say, 1 unit will increase by 8 to 10%, and 6 unit or FFP will increase the coagulation profile to 30%. So we say how much has to be the coagulation levels to maintain that patient doesn't bleed. It has to be 100% of everything or no? Till my coagulation profile falls to 30%, I will not be bleeding. So that is what is required. Our dosing is based on those things. 6 units of RDPs, 6 units of plasma means that we are trying to maintain a coagulation profile of 30%. Not the 100% activity, but at least a 30%, which will prevent the patient from bleeding. I think this is more important, which when it comes to crossing over of blood components. If the patient is of O group, the PRBC which can be given is O. For an A and O. For B, it is B and O. For an AB, A, B, A, O. That is a sequence where B is given first and A later. It depends on your inventory. A can be given first and B can be, but in India, we have around 38% of B positive patients, donors. So we give B more because we don't have an inventory of A more in comparison to B. Similarly, everything flips when it comes to plasma. The universal donor of red cell becomes a universal recipient of plasma. So a group O patient, when it comes to FFP, can take FFP from anybody. whereas AB positive can take an AB group can take FFP only from AB. I think this is clear. It's a very this is a scenario changes when it comes to red cell and FFP. For platelets, single donor platelets are given group specific. If you don't have a group, what we do, we add a platelet additive solution to the platelet component and give. So across the group, it can be transfused. RDPs are given without groups. That is, we don't require the group matching before giving a random donor platelet. For RH positive and negatives, I think this is important because what happens at times we don't have an RH negative inventory in our hospital. So RH negative patient can receive an RH positive unit provided the patient is not a female and not from a childbearing age. If the female is from 15 to 45, we avoid giving a positive unit. Rest with a proper cross match, O negative patient or an A negative, B negative patient can be given a RH positive unit. In case of FFP, we don't require any RH matching. For platelet concentrates, if it is negative, a dose of NTD immunoprophylaxis, that is 1500 international units, can be given, which will keep the patient safe for 7 SDPs and 30 RDPs. That the patient will not be forming NTD if exposed to RH positive cells. RH is a feature of which cell? Hmm? RHD is a feature of which cell? Red cell, plasma, platelets, WBC, leukocyte, lymphocyte, monocyte, which? Yes, it is patented by red cells. It only RH is found on red cell. Platelet doesn't carry. Why we call about platelet concentrate? Because during collection there is red cell contamination, so which might cause an RH isoimmunization in the patients. So the same dose is given to pregnant females to prevent RH isoimmunization. That is hydrops fetalis. These are storage condition. Red cell is stored at 2 degrees Celsius. Platelet room temperature. FFP at -20. Has to be transfused within 4 hours, within 4 hours, and within 6 hours. I think I should skip this is something which you'll learn during the course of your practices next 3 years. This is also next 3 years. Important. There are 3 types of requests what you raise from wards to blood bank. Immediate, urgent, and routine. Try to understand this thing. We have been helping you, but this is what is, if I do, I'm safe. Immediate means I'll give you an ORH negative unit. You have to transfuse irrespective of the group. Urgent means I'll do a group and immediate spin. That is, I'll take 10 minutes and you'll get the unit. And routine means I'll do a full cross match and kill. So whenever you are raising a request, try to understand whether it is immediate, urgent, or routine. Routines are basically those surgeries who are planned for next days, or the transfusion, which know that patient will be requiring transfusion in the day. You send in the demand in the morning and the patient is transfused in the evening. Immediate as usually happens in OTs when the surgeon says, see, this is aorta and this is IVC, and unfortunately the scalpel is pointed towards the vessel. So the third part is adverse event. Your eye sees what your mind knows. If you don't see any transfusion reaction, you will never be able to recognize it. You have to first recognize the transfusion reaction. All units carry equal amount of risk, be it red cell, plasma, or platelets. So we need to evaluate, manage, and report. This table will help you in identifying different types of reactions. They can be acute hemolytic transfusion reactions. How? Because they will never have rashes. Rashes are patented by allergic and anaphylactic reactions. If the patient is having hives and urticarial rashes, probability is that the patient will be having allergic or anaphylactic reaction. They won't be having hemolytic transfusion reaction. Similarly, based on signs and symptoms, we can decide which type of reaction it is. I won't be going in detail. In some other course, you'll be covered this part also. Whenever there's a reaction, this is the history which has to be sent to the blood bank or is required by the blood bank. Diagnosis, which gives exactly why this reaction might have happened, history of transgender pregnancy, because these two conditions might have a predefined or preformed antibodies in the patient, type of blood component, because allergic reactions are more common with plasma because they carry plasma proteins, or platelets because they're stored at room temperature. History of transfusion reaction, thalassemics, they tend to have more transfusion reactions. IgA deficiency, they say IgA deficiency occurs, but in around 20,000 Indians we tested and we didn't find a single IgA deficient individual. And medications, which medication has been given along with the transfusion. Clinical information, whether warmer were used, infusion pumps were used, what was the bore of the needle, or whether any cell, fluid was given along with the red cell transfusion or not, pre and post vitals. This thing, but you'll find these things you'll find on intranet. There's a book which we have uploaded on the intranet, blood transfusion manual. These things are there, which will help you in understanding the details and why we require all those things. Then these the investigation which has to be raised whenever there is a transfusion reaction: CBC, plasma or unitary HB, bilirubin, LDH, CRAT, a coagulation screen to see whether the patient has gone into DIC or not, and cultures if there's a suspected septic reaction. These are the samples which has to be sent. A clotted sample, a EET specimen. After 5 to 7 hours, a clotted sample for bilirubin and first white urine. So 4 samples, 3 samples to blood bank, 1 samples to biochemistry. Done. And whenever there is a hemolytic transfusion reaction, I think nephrologists might not agree with me. The renal function returns back in 14 days. Suppose you give a B positive unit to a A positive patient, and the patient goes into a complete AKI. That function will take at least 14 days to come back to normal if we have not killed the kidney. Okay. Maintain the hydration, the patient will be fine. I think I finished off in just 14 minutes. Thank you very much.